is why we need to redose. This is why the importance of breaking the seal on the mask. I mean, there's no excuse on this mask at all. It's super easy.
It's easy.
I think that's a perfect lead into what should be a concern, but it is not as prevalent as is necessarily made out to be, and that's this we're going to crash everybody's blood pressure.
Well, let me ask you this.
Everybody's blood pressure.
What is the biggest risk of using this poorly? What is my biggest risks to the patient?
It's going to be situational dependent.
Sure.
So it's going to be based upon like having a low blood pressure, and we can talk about the physiology of having low blood pressure and positive airway ventilation. If they have a pneumothorax or some type of lung injury, we can exacerbate that situation. If we aren't paying attention, the patient vomits and then aspirates. Those are your big risks.
So these are the biggest risks, right?
Those are the biggest risks, and those are all situationally dependent.
All situationally dependent, but they're also all very well picked up on.
Correct.
If somebody's vomiting and I'm not paying attention, that's on me. I
That's
should
on-
know
that's
that
on
they're
us,
vomiting.
right.
If they have attention pneumo, I should be able to pick up on the signs and symptoms of attention pneumo very easily.
Yes.
And then the last one you gave was a lung problem. Attention pneumo. What was the third one you gave?
I said blood pressure.
No,
Blood pressure.
So
I
hypotension.
should be trending my vitals.
Yes.
So if I'm not trending my vitals,
They're
I'm not
vital.
doing my job.
They're vital for a person, for a purpose.
Yeah.
They're
They're vitals of life.
Yeah.
and like I was telling you guys off, when we had taken a break, the times I've gotten into trouble personally with hypotension on cases
Was hypotension?
were cases where I was getting a little cocky and the blood pressure was marginal to begin with, right? And I'm like, the patient straddling that line, right? Their heart. They were both CHF cases, by the way. Presented to me with all the classic signs and a marginal blood pressure. And my mindset was more CHF, not cardiogenic shock, right? So I had this heart that was failing as a forward pump. I thought I was still in the failing category. Pressure was marginal. I was trying to be all kinds of cool and tweaking a little bit. Ultimately, like we said, I didn't just blast it to 10, right? Go, here's 11 for good measure. But I'd worked them up to 10, and they were holding, and then they decided their heart was going to fail as a forward pump, and so in both my cases, we stripped the CPAP. And we just went back to a non-rebreather, and again, this is dated information. This is 10, 12, 14 years ago. Stripped it off. It was right at the inception of.
Don't date yourself, Scott.
We went right back to the rebreather. And I'm like, I expect in those cases for that blood pressure to recover. And I think in most cases it would have recovered, but I had basically helped him in a cardiogenic shock. And, at that point I did wind up going to pressors. And, at the time it was dopamine. Today it will be far easier for everybody watching this, with push dose epi, right?
Yes.
That does bring up another solid little point is with the push dose epi, we've made blood pressure management so easy. There's really no excuse to deliver anybody under most circumstances to you hypotensive. Gone are the days of, I started the IV and I was waiting for the fluids to catch up, right?
Yeah.
That's over, right?
Or I'm trying to make this drip and do the math and the push dose is so easy to make. It's quick.
I won't even dive on how terrified I was as a young paramedic of dopamine and the math. It was a physician colleague, friends of mine that basically had to beat it out of my head like there's easy ways, there's cheats here, use the cheats. But besides that, the times that I've put it on and made the patient wildly better far outweighs these couple of cases. And do they happen? Should you be able to identify them? Yes.
Blood pressure related.
They're outliers. They're outliers.
I think it's warranted to talk about what does CPAP do to the blood pressure and why. And I think that as easy as I can explain it, and then you guys can pick up where I don't understand it, because I'm just a paramedic, is that
says the guy running a paramedic program. Right?
I'm messing with my preload, therefore I'm messing with my afterload. There's these things called Starling's law and such, right? So what I'm doing is I'm increasing the thoracic pressure, therefore I am
Well,
not...
I'll take one step back again. Normal breaths.
Yeah, there's double hit here.
Yeah.
Normal breaths are negative
pressure.
pressure. Negative pressure inside the chest actually gives increased blood return to the heart.
By pushing on the descending and ascending...
So if all things are equal at this point, I take a breath, negative pressure in the chest, blood will flow into that negative pressure area.
Right.
So that's normal, and then the heart goes, hey, I've got extra blood, which we call preload, right? So preload's pressing on the heart to give it more volume. Heart contracts to generate that pressure to move blood forward. So
now
out of the right side of the heart.
Take that out. Now I've gotten the pressure, and just like I'm pulling back on a plunger on a syringe, the inside of that is pulling the air in. Now I've pushed that out with CPAP.
Correct.
So now what's happening to my preload
is it's going down.
It's going down. So now my afterload's affected. So my heart rate, or not my heart rate, my blood pressure is coming down.
Correct.
So that is kind of the most simplest way I think we can explain that.
Yeah, it's a double hit. You take away that augmentation that we get with breathing, right? And we also then double down on inner thoracic pressure and reduce blood flow back to the heart. It's double whammy.
Correct.
Both things are hurting.
Well, and in a lot of cases too, you're taking away the anxiety aspect of things because patients can breathe now, and that's also calming them down.
So you're getting lower catecholamine release.
Mm-hmm.
And central venous pressures are actually relatively low.
They are.
It's
You're about 5 to 6, normal.
Yeah.
Normal people.
Yeah, and I have the math already done out here because I'm not going to remember this stuff. But and we're adding centimeters of water as our pressure measurement on CPAP. Of course, we're measuring all pressures in our body in millimeters of mercury, and about 1 centimeter of water is about 3/4 that of 1 centimeter or 1 millimeter of mercury, right? So if you put them on 10 centimeters of water, right, and you don't have, let's say they're vascularly dry or the pump is shot, right, that translates to about 7.5 millimeters of mercury, right, of pressure in the chest. And you're saying, hey, 6, 8, 10, range, we're already right up against it, right? So there is potential for error, and those are my cases, right? I just think, hey, I'm here to help, and I'm not helping, right? I helped you into cardiogenic shock, and then recovered from that, right?
Gently.
It was turn the knob slowly. All these now are coming with some sort of HEPA filter or some sort of,
and it is important, as Ray pointed out, to have it in the right spot too, though.
To have it in the right spot, and just to use the damn thing, right? And these come pre-assembled with them on, which is fantastic. Those I believe they just come in the bag, right?
Correct. You have to assemble the filter in the mask.
The ones that I had, when we had this at our shop, they didn't exist. And we also weren't as sensitive to things as we are today, post-COVID. But
so other contraindications I want to talk about would be like facial traumas. Remembering that we've got these full face mask seals. If you've got a beard or lots of facial hair, that's going to obstruct your ability to create a good seal and create that pressure. And obviously facial trauma, you won't be able to create a seal whatsoever. And that's when you're just going to jump right to that intubation if you're that level of provider.
You've a couple of times gone back to, hey, transitioning that patient to a BVM if they fail the CPAP for whatever. So they do get sleepy, they do go out on us, whatever. I got to throw my plug in here as I think an underutilized and underappreciated device that should be pretty much standard of care, right, is
PEEP valves.
You just took, right, so let's say you had them up at 10 centimeters of water, and let's say that there's no nonsense with the blood pressure going on, but now they're snoring, now they're retching, they're going to vomit, whatever the case may be. But vomiting's still a bad example because of a mask. But the point is that you're going to transition them to a BVM. So all that continuous positive airway pressure that you were creating with your device, as soon as you transition over to the BVM, is temporarily positive, negative. Well, I say negative, zero, right?
Yeah.
Right. Temporarily positive, zero, right? And I feel like, and I know in your case, in your jurisdiction, you have a vent unit, right? And you're taking patients off ventilators, and this should kind of be in the forefront of our mind is if they're on PEEP
already,
which is physiologically the same as CPAP, right? And we're talking about doing the same thing to the alveoli, right? And the same pressure in the thorax or in the lungs. You strip them from the vent, you just bag them.
You lose the PEEP.
You lose the PEEP, right?
Yeah.
You lose that oxygenation. Yeah. So
but this is such an easy device.
Underutilized, and I think underappreciated and inexpensive, right? I mean, $8, $9, and if you use it, the hospital finds you one. They'll replace it, right?
Maybe.
They'll replace it. I had a high-ranking person in UH say, "We will replace it for you." But yeah, that's the, that's my pitch.
They're helpful. I think the caveat's got to be is if they're a trach patient and you're hooked up with a trach, make sure balloon's up. You've got a seal. If it's an ET tube, great, you've got your seal. But if you're going to use a PEEP valve on a mask like that, you have to maintain that seal, just like we do with the CPAP. Because in order to maintain that pressure, you have to have a seal.
Constant.
Cannot be broken. And that's where this is great.
Yeah, and that's where, and I guess I approach that from Caleb's transitioning, so it's already strapped to their face, right? Actually, you know what? Can we do that with? We can, in fact. It will adapt. That's in the inside diameter. That is 22 millimeter. Mm-hmm. Absolutely will work on that mask as well.
And I think the real way for providers to understand it better is go to a pig lab, right?
Yeah.
So if you do a pig lab,
which, by the way, if you want one, whatever department you're at, we'll get it for you. I have connections.
You have a hog hunt coming up. Got it.
I was going to say.
Katie from AirMed. We will hook you up.
But if you utilize, I think that's the best example for EMTs, intermediates, paramedics to see is we did a symposium, right? And we had PVC pipe, pig lungs, and then we showed a non-PEEPed BVM, and then you show a PEEPed BVM. And you immediately take them from that unit that's been utilized in PEEP to keep those alveoli sacs open. We're getting better oxygenation. The patient's improving, and now I switch to this BVM, and it's just inflate, deflate. Mm-hmm. It's gone. It's instantaneous. Whereas if I can utilize that BVM with the PEEP, I'm trying to mimic or reproduce what I just did and keep those alveoli sacs at least 50% inflated. So I'm getting better absorption. I'm getting better oxygenation. They're not going to be as hypoxic. It's just so beneficial. But I think for the visualization of that with the ping lugs, I think is the way to go. It's just, it sells people on.
Absolutely.
Right? And it's not an expensive device, but I think it really puts it in perspective, right? Because we're see it, touch it kind of people. Yeah. We're see it, touch it kind of people do it. And that just makes it so much easier.
Maybe I'll cut in a video right here of it. I mean, that...
it's worth it.
If you can't make it to a pig.
I think Rescue Pod had a little thing they sent out for a while with the balloon inside of it. It's the same concept. When you saw it work with the Rescue Pod, the balloon would inflate, deflate with a regular BVM. You attach the Rescue Pod, inflate, stay inflated.
Actually, that would be a better example for our negative pressure discussion.
And for the providers to understand that, remember, gas exchange doesn't happen just when you take a breath or just when you exhale. It's constant, right? So you want to get the air into the alveoli so the constant gas exchange can happen at the alveoli level, and then we're going to cause ventilation to take the CO2 that's accumulated in the lungs, expel it out of the body, and then get oxygen into those alveoli to have that process repeat. And the more alveoli we have, the quicker that can happen.
Yeah. And I think one thing we really haven't touched on a lot, we've mentioned it, but it needs to be utilized more, is capnography. I mean, it's bigger, it's better. We should be using it just like we do SpO2s.
That does bring up a unique situation with especially high volume and high flow systems, right? If I put a sampling cannula under there is some dilution that goes on. I mean, that sampling cannula is only pulling X amount, it's pulling so fast. And if I'm just rushing all of the exhaled, gas essentially across it or past it, you're going to see some artificially low numbers, but that is still a number.
It's something we can trend.
It's still worth trending, right? And that's my,
As long as it's constant and
Correct.
what it is, I can trend it.
Yeah, they're like, oh, it's a washed out number. It's not reflective
But
of.
it's
No,
still
you're absolutely
trendable.
right.
It
It's not
is.
reflective of.
Correct.
But you can tell which direction you're going. It's a triage
Yes.
tool, right? And you can use that to your advantage.
Without getting into the oxygen saturation
And-
dissociation curve,
And let's
this
not
is
even
easier to
let's not even
use.
get into the comparison of end-tidal CO2 versus PA CO2 for another time. We could probably do an entire talk.
Oh,
just
yeah,
on-
two of them.
We want that number to
Oh,
trend
yeah.
down, and you should even see it trending down from the time you put it on. Note that number to your reassessment in transport, and reassessment again in transport, and then when you drop them off, that number
That should
should
be
go
going
down,
like
and
this.
then all your other indicators of what your work of your intervention should tell you that it's getting better. Because that number continues to go up, and then they're not breathing as much. We've now failed and have to move on to something else, which is going to be BVM for our basic providers, and then consideration of intubation.
Yeah, advanced airways. Specified.
Advanced airways, because I am a
Advanced
big
airway.
proponent
Yep.
of supraglottic airways and not necessarily
Whatever is the
intubation.
safest.
Correct.
For your patient.
Safest.
Yes.
Eye gels.
And we'll have to have that talk too, because
Yeah.
there's finally some data from the pre-hospital world showing at least equivalency in outcomes, and that's I think we'd already previously talked about the pulmonary edema and the CHF, and that the advantage specifically of the pulmodine is you can get the nitrates, and you can continue to give the nitrates, and talk about misconceptions and dogma. Once you put it on, you can't ever take it off. You can't break the seal. Well,
Yes, you can.
well,
And yes, you should.
especially in CHF, right?
Yes.
It needs to be said that remember, you're treating the side effect, the pulmonary edema, the side effect of the real cause here, which is a failing heart, right?
Correct.
You have a heart failing as a forward pump.
But I'm not taking
The
it off.
secondary, you're breaking the pressure.
It's
right?
okay.
You're interrupting the pressure, but specifically for those cases, those CHF cases, you have to, because we got to keep feeding them nitrates. And with that revision here in 2022, and I'm very passionate about
Yes,
that, and
100% repeat dosing.
wanted to go way beyond that.
Yes.
Provided your pressure's holding.
Yeah.
Correct.
Yeah, so but keep feeding them nitro every 5 minutes until until that pressure is continues down, and 120 is our target here. But I know.
But we're not
we've
treating
spoke-
hypertension either, which is what needs to be talked about.
I need to. Well, isolated hypertension, not in the case of this. We actually want to make the path of least resistance for that weak heart forward, right? By just dilating, It's a friction loss problem for our firefighters, right? So we're
Yeah,
going to put a
the
bigger...
100%.
Yeah, we
That's
have
a good way to
absolutely...
explain it.
Yeah,
the
no,
side
we
effect
want-
of what we're doing is treating hypertension, but we're not treating hypertension.
No, yeah, it's not directly.
it's-
Yeah,
correct.
Yeah, we're trying to dilate the vessels to make that forward flow that is backing up into our lungs. That's killing us. So I think people have lost sight of that, and we've not just. And that's why we really kind of started hammering again. Is the nitrates, and I know even some of in my house, some of my providers like, you really want us to give this every 5 minutes, and they're concerned about the amount that we're giving, right? That seems like a lot. And what I really want to hear from you is, like, if you do a nitro drip, how much you might, not nitro drip, or even, I know you got a nitro bomb on cue for me as well.
I do.
But, and then I want to translate that into how much we're actually giving mathematically. So our 400 mics every 5 minutes, well, that's about 70 mics a minute. I bet you have a different experience as an ER doc with the amount of nitro that you give.
I will, and I've gotten pushback from nurses too that haven't worked with me, that if these patients are coming in extremis and they're hypertensive, we're talking typically systolics, 170s,
180,
180s,
190, yeah, yep.
200.
210, yep.
I will nitro bomb them. Take that CPAP off, 3 tablets.
This is not
sublingually.
protocol.
This is not protocol.
This is not protocol.
but you can see it in the emergency departments that we're going to nitro bomb them, and that's our first attempt, because I can get sublingual, subbuccal nitro to the patient quicker than I can a nitro
Nitro
drip.
drip, sure.
So I bomb them. Their pressures are going to handle it. They're going to come down a few points. It's not going to bottom them out. They're going to keep them on CPAP. They're going to feel better after a few minutes, and then I'm going to order my nitro drip if I even need it. I might have vasodilated them enough that I've gotten fluid to start moving in the right direction. I've got positive airway pressure pushing that fluid back into the vasculature. I've given my Lasix that said diurese them. I might have moved everything forward already that I don't even need my nitro drip. But I have it there if I need to use it.
Yeah. You've given enough of a loading dose, essentially, so
Yep.
you might not need that
Yeah,
maintenance
you get
dose,
them
right?
over the yeah, exactly. And what are we talking about a nitro bomb? How many?
So nitro bomb's 3.
In your mind,
It's just 3.
It's 3.
It's 3. So typically when we're talking about ACS and we're talking about protocols, it's going to be 1, and we even do this for ACS too. It's like if they're having chest pain and we're treating that chest pain, it's going to be 1 nitro tab sublingually every 5 minutes to improve as long as their blood pressure is okay. So that's no different from ACS, and those patients are typically way more normotensive than our patients that are in pulmonary edema that are super hypertensive, right? You've got a lot of room in that blood pressure.
Absolutely.
Maybe going to cause a headache, but
Yeah, sorry about your. I'm glad you can breathe now. I'm
Yeah.
sorry about your headache. And let's say you did have to, transition to a nitro drip. They laughed at your first 1,200 mics, right?
Yeah.
Now I want to make it clear that maths out to 1,200 mics. We're giving 400 every 5 minutes, right? And this, and he just walked in, and Dr. Cox did and threw him,
Yeah,
threw a handful in,
whatever lands,
whatever
we're a
stuck.
perfect
Yeah,
dose.
that's the right dose. So he, Dr. Cox, and he throws all that in, and then when you transition to a nitro drip, how many mics? I understand some of it's case dependent, but give us a range here so we can kind of understand that we're really not all that. We're really not all that aggressive with the nitro,
no.
even if every 5 minutes.
I have no idea what the dose is.
Excellent.
Do you know how often I order a nitro
So
drip?
there it is. I think the proof is in the pudding right
Obviously,
there.
right there.
I have to look it up. I don't know what the dose is because I don't order it enough.
That's fine. I think that speaks
Yeah.
volumes.
I think that says enough.
That speaks volumes.
I can manage them without a nitro drip.
Yeah,
But I think
They're
the
super
takeaway
sick if
point-
they're on a nitro drip.
sure.
Well, and I think the takeaway point from the nitro bomb now back to protocol or compared to EMS is this is why we need to redose. This is why the importance of breaking the seal on the mask. I mean, there's no excuse on this mask at all. It's super easy.
It's easy.
No,
1 or 2
that's-
clips. This one, I agree. I use this product. The webbing for the head dress, if you will, is a little bit more difficult to deal with. Maybe just undo the bottom
But
two,
it's
pull
doable.
up,
Under bottom two,
nitro,
tip it up.
doable.
boom, go back. But it's doable, right?
It's absolutely doable. The
It's
only
just-
issue I did see is that with Go Nitro, the powder that we were using for a little while was kind of poof.
So
Yes.
And then everybody in the squad had headaches.
You're crop
and then-
dusting your partner.
But I
yes.
think that we've since kind of starting to move away from Go
Yeah, we're
Nitro and
going
go
back
back
to
to
the
the
tabs.
tablets.
Yes.
Which Go Nitro had its pros and cons. It was the powder Nitro. I think you were almost always getting the dose. We don't know how much of the Nitro tab itself is actually settled to the bottom of that little glass
what's
container.
what's shipped off.
Yeah,
Sure.
but
Yeah.
I still think you're getting a
Pros and
dose.
cons to
so-
If you
that.
want Go Nitro, just dump all the tabs out and then
Right in your
put the
bare hand,
powder,
right?
And put the powder in, yeah, in your bare hand, and then rub them together.
But yeah, so that
Speaking
was
of
an
head-
issue though, breaking the seal
Yeah,
with the
just
Go
because
Nitro.
it
It was
was-
just going everywhere.
It's a particulate at that point. Yeah.
I came back to the firehouse and took Tylenol for my headache.
So, yeah, absolutely break the seal, especially on your CHFers.
Yes.
I would say refrain on all your others because you want to keep them.
Correct. And that's the big thing
You
that
wanna keep
providers are
them-
going to have to know. You know, is this? Am I dealing?
What am
with
I
it-
treating?
What am I treating?
Yeah.
Is this a chronic bronchitis patient? Is this a chronic emphysema patient? Like, what are we treating? Is the big
It's
thing
so much of this is going to come from your patient history taking.
Yes.
So get it early while you can get it, because you may be the only one who gets it before he gets it.
Correct.
here. Yeah.
So if we're intubating this patient in the field, let's say, where they crash on us, he's not going to know any of this. So we need to get it before that happens. So
Correct.
if you
And
can, get it early.
And with the history, one thing we didn't discuss a lot is CHF versus pneumonia, right? So my history is key there. So if I call 911 at 3 in the morning because I can't breathe, when did this start? Well, it just started 5-10 minutes ago. I'm going to lean more towards CHF without a fever.
Sure.
It's acute versus, well, I've been sick for a
3
week. I've had
days,
a
yeah.
cough for
Mhm.
3 days.
Yep,
you know,
yep.
a longer period of time. I have a fever. I'm giving you
Febrile.
different.
I've been sweating a lot.
Yeah,
peeing a
I'm giving you
lot.
different signs and symptoms. Both, this is going to apply for both of those patients, but the nitro's not. So that history, Caleb, you have a very good point. The history is very important to be diving into, paying attention to, asking the right questions.
And I touched on those non-cardiac pulmonary edemas as
Yes.
well, right?
Yeah.
Not necessarily indicated. Not all of those, right? Maybe even any of those.
One thing I like to ask my asthmatic patient always is, have you been in the hospital for this before? And have you ever been intubated for this before?
Yep.
And if they have been, it's one of the first things I'm going to relay to the physicians when I get there is, this is bad.
I'll do one extra. I will ask people, have you been placed, anyone that comes under distress, have you been placed on CPAP or the mask before?
That's good.
If
Yeah.
they say
no,
yes,
that's-
You
I go,
know it has potential.
I go, do you feel like you need the mask now? Yes. Great. Call respiratory.
and you're
Making
going right
process
for
done.
it.
Yeah, I don't have to do it. Yeah,
It's easy,
I'm not.
yeah.
I don't have to do it. Yeah, I've been this bad before, and I need the mask, and it's helped. Great.
do
I'm
it.
calling respiratory. We're getting you on the mask.
Absolutely.
Do that pre-hospital. Yeah, I've been on the CPAP before. Have you been this worse? Like, do you feel like you need it, or are you worse now than you were then? If they say yes to those answers, put them on.
Yeah.
And I think it's generally good practice that if they know about your equipment, probably need it.
Well,
so
the Dilaudid?
They
yeah,
use it.
except the Dilaudid, yeah.
They get that yellow
it's
box
that
thing.
drug that starts
Yeah.
with a D. But yeah, if they walk in and you're like, did you bring your yellow box? And do I need it? Yes.
Yeah, then you
Be
know.
right
I
back.
believe you.
And the
believe you.
patient I alluded to earlier that I had
Yeah.
intubated a couple times, she was one of those. This is bad. I'm going to
Yeah.
end up being intubated again. She told us that once.
Yep.
It was like, oh man,
I
they
know.
know. They know.
I had one of those. It says I was just here a few weeks ago and I got intubated for this. I'm like, no,
Cool.
you're not.
Yeah.
I
CPAP.
BiPAP'd her.
BiPAP, but yeah.
in the hospital. So I BiPAP'd her and she did not need intubated because she said,
Gotta
I
have
feel
it,
bad and I
because
got
you gotta have
intubated
it.
last time.
Yeah.
Great. We're not going to do that
gonna
this time. I'm going to intervene before.
It's something
that
we
happens.
kind of talked about, but I think it's worth mentioning again on your end. If we can keep somebody from being intubated, we've saved them a lot of time, a lot of money,
Yep.
an ICU stay, probably pneumonia, all,
Yep.
all these lists of things. And why not start with something less? I mean, it just makes sense.
It absolutely does.
100%. Yeah, I mean, and a lot of things that we don't think about maybe pre-hospitally is the financial burden of that, right? So, not to get off track, talk about solumedrol, decreased length of stay.
Yep.
Now look at CPAP is the same way, decreased length of stay. That might be 2 or 3 days that now their insurance company or they're going to have to pay a portion of that patient's going to save too. So financially, it's going to be a win for them. It's going to free up a bed for us or somebody
it's
else
for
that
the
needs
next
it.
guy
So
I'm bringing in. Yeah.
yeah,
the
so I
patient I'm
mean,
bringing in.
it's a big circle here to try to help alleviate some of that. So
Well, from the hospital side, like if you guys do early CPAP and you catch them early enough, I do my workup. They improve to the point that you guys are on scene, put CPAP on. You had your transfer time of 15 to even some places I run is 45 minutes. They get that time. They sit in my ER. I do my workup. They're saying, I feel better. I can trial them off BiPAP. And if they're maintaining, they don't need an ICU. They don't need a step-down unit. Now they're on 4 liters nasal cannula and they can go to a floor. And that's-
Steroids.
Well,
Yeah.
that was probably on.
Yeah.
Yes, it was the BiPAP. It was the CPAP. It was steroids. It was those early interventions that now I'm 3, 4, 5, maybe even 6 hours in because I have aborting issues that I can now go to a lower level of care for this patient. And they don't need all that money, and they're in the hospital less time.
Yeah.
It's
It's a-
less resource utilization for a patient.
correct.
By if
Win-win,
you're
Yeah.
going.
Yeah.
100%.
Absolutely.
But I think a lot of times we don't talk about that. You just don't,
true.
right? It's like, I brought you a patient. They're sick. I'll bring you another patient in 20 minutes. They're also sick.
Yeah.
You know what I mean? So it's,
Right.
I think a lot of times we don't look at that long term. We do with
And we-
time
but-
critical medicine like STEMI, strokes. Hey, I want feedback. But a lot of people don't want feedback on that CHF
Don't
patient.
take
It's
the time.
You're
they don't take the
exactly right.
time to really understand those
And then some
details.
people won't give the solumedrol because they don't see the benefit of it in the ambulance. No, we
Correct.
might not ever see the benefit of it,
No.
but the hospital will.
Yeah.
Unless
So-
you're transporting for 6 hours,
Well,
you're not going to
yeah,
see the
yeah,
benefit.
exactly.
Yes,
If you see
100%.
the benefit of this, then
Something's
it's
gone
a
terribly
really
wrong.
bad day.
You
Yeah.
got lost in
When the
process.
patient is discharged
You ran
the
out
next
of
day
fuel
and you see
first.
him the next day, you'll see the benefit of what you gave. But
Yeah, sure. But it's
But
important.
that is not and the point needs to be made is it's not an excuse to not give it. I mean,
Exactly,
you
that's
know,
what I'm
our
trying to
patient-
say. Just
our-
'cause
our
we don't
patient
see it,
our patient
it's
advocacy,
there.
Yeah.
Yeah,
And
it's there.
I mean, Christ, there's just studies now on that on EMS steroids. I mean, they're
Yeah.
damn near 20 years old at this point. I mean, we've known this forever, but it's still incumbent upon us to pull the trigger on it.
Well, you guys don't see the benefit of a STEMI activation
Not at
to
all.
your patient, right?
Not at all.
You still drop them off in the ED. You go back to the next call. You might see the benefit when they call again, like, "Oh, you survived."
Yeah, all right.
Yeah, thanks, guys.
Or you might get the thank you chicken a week later.
That's-
True.
Takeaway points for CPAP. We'll just splice it in right there, right? Those takeaway point. So
I mean, I think in closing, the big thing was like utilize it early. It's going to benefit the patient. If this is an EMT level skill that can be done, so it's not IVs, fancy drugs. You're going to make that positive change in that patient's outcome through length of stay being shorter, decreased bills, but you're also going to make that patient better faster at an EMT level. It doesn't matter if you're a paramedic. This is the priority. Yes, we talk about nitro and how that's important, and the addition into that with other levels, and as you follow the protocol even further. But I think the takeaway point would be utilize it early.
generally easy,
It's easy.
very safe.
Not too many contraindications.
Not too
And
many
the ones that do
There's a
exist
few things
are-
to be concerned about.
Minor
but
risk.
Nothing that should
Yeah.
really inhibit you from.
It should definitely
Pulling
be
trigger.
another tool, just like in our fire engine. We don't use them all, but there's always tools. Utilize it when it's needed, and it's not often that we should not be using it.
It's one of my favorite tools inside the emergency department to have CPAP or BiPAP on these respiratory distress patients. It's gonna save you. It will save you from having to do the extra step of intubating a patient or having to deal with a deteriorating patient. So,
I think, like Ray mentioned earlier, I think that we need to think about sending these out for service when they're needed.
Yeah.
A lot of people have forgotten that with these particular units. That's one of the reasons I do like these disposables. There's pros and cons, I think, to each of them, but I not drastic.
No.
Not drastic. They're basically doing the same thing.
Subtle operational changes. Yeah,
Yeah, and both very good products.
absolutely.